Good evening to all my Indian friends and good morning to all my American friends. Welcome to this weekly webinar presented by the American Academy of Yoga and Meditation. American Academy of Yoga and Meditation offers a global platform to all those who would like to share their knowledge in yoga and its importance in health and wellness. And in view of this, we conduct weekly webinar on the importance of yoga and meditation as medicine for prevention and cure of various diseases. Today we are going to understand the epidemiology of cardiovascular disease, which is the cause of almost one-third deaths worldwide. As per the WHO data, 17.9 million people died of CVD in 2015. Every 36 seconds, America loses a life to heart disease. India is soon becoming the capital of cardiovascular disease. The premature deaths and management of the disease results in loss of productivity and further burdens the already strained healthcare resources. Welcome to this live webinar to understand the epidemiology of cardiovascular disease from our experts Dr. Brahma Nanda Sharma, Dr. Dibbendhu Khanra, and Dr. Narayan Namboodiri. Dr. Narayan Namboodiri will be chairing the session, and he is a professor in the Department of Cardiology at the SCTI MST Trivandrum, Kerala. He did his MD and DNB at Pijimar, Chandigarh, and fellowship in cardiac electrophysiology from the Royal Hospital, Australia. Winner of many awards and accolades, he is the immediate past honorary editor-in-chief of the PubMed indexed medical journal, Indian Pacing and Electrophysiology, the official journal of the Indian Heart Rhythm Society, and a member of the writing committee of the Asia Pacific Heart Rhythm Society since 2015. He has 146 publications in indexed medical journals and has written 12 books, chapters, and many articles. He is presently involved in many prestigious and significant research initiatives as a principal investigator. Our first speaker of this webinar is Dr. Brahma Nanda Sharma. Originally from Jaipur, Dr. Sharma is a professor at VA Medical University of Pittsburgh, USA. He is an interventional cardiologist with more than 45 years of experience in medical field and has been actively involved in bringing focus on prevention of heart disease in South Asians in USA and India. He promotes the practice of meditation in mastering the mind for managing problems of stress and anxiety. Dr. Sharma is the AAPI chair of American Heart, South Asian Heart Disease, and the co-chair of Global Cardiovascular Burden Forums. Dr. Sharma will be speaking on epidemiology of South Asian CVD. Our second speaker today is Dr. Dibbendhu Khanra. Dr. Dibbendhu Khanra is a DNB DM cardiology and is pursuing fellowship in electrophysiology and devices in Royal Wolverhampton NHS Trust, United Kingdom. He has been awarded as a Young Cardiologist of Tomorrow in ESC 2018 Munich. Winner of many awards, Dr. Khanra has more than 30 PubMed indexed publications and multiple book chapters and has presented in multiple international forums. He aspires to gain more experiences of complex ablations and devices. Today he'll be speaking on epidemiology of atrial fibrillation and Indian perspective. Over to Chairman Dr. Namboodiri. Thank you.
Namaskar. Thank you. Thank you. Good evening and good morning, because we meet from different parts of the world. Can I have my presentation on more so that I can start? It's a great privilege for me to be here in this session. And at the outset, I should express my sincere thanks to Dr. Roy, Ms. Anjali, and other organizing members for having invited me to deliver this talk. Full screen, please. Can I have full screen? Next slide. Can I have the next slide? Can I have the full screen? Okay. This in this session, we have two brilliant speakers, and they speak on two various aspects of cardiology in Southeast Asian population. And the main one being the epidemiology of coronary artery disease in this part of the country, part of the world, and the ways to tackle that with a novel, meditation technique that is, it's actually not novel, described more than 2 millennia back by Patanjali and Yoga Vasishta also. So this has been, the yoga has been practiced. It has now given a new life by the investigators all across the world. And uh, we have two speakers in this regard. And the first is on the epidemiology of coronary artery disease in Southeast Asian population. And the second one is on the epidemiology of atrial fibrillation, predominantly discussing the various aspects to prevent this particular new pandemic. It's called a new pandemic. Atrial fibrillation in the field of electrophysiology is called a new epidemic of AFib going on in the world, with a lot of cases being reported, elderly population, multiple comorbid factors, and all these aspects. So over to Dr. Sharma for the initial talk, and thank you.
Okay, can you see this? Can you hear me? Can you hear me? Hello?
Yes, doctor, we can hear you, and
Okay.
we are not able to see your presentation yet.
Okay, I'm going to the presentation right now.
Yes, doctor, we can hear you.
Okay, can you see my presentation now? Okay, I'm going to the presentation right now.
No, sir.
Yes, doctor, we can hear you. Okay, can you see the presentation now? Let's see what's wrong here. I need to do with the. Remember, you told me to share. Okay, let me try share. Okay, share screen. Remember, you told me to share. Okay, let me try share. Okay, share screen. Where is the applications here?
So what you will have to do is click on the share window, and
Yeah,
then select.
I am. It's not working. So where do I go for? I'm doing share screen, and then it says share screen here, and then remember yesterday you told me go to the applications, but that is not coming.
Okay. All right. We'll do a troubleshoot with you, sir. In the meantime, may I request Dr. Namboodiri to run his presentation and take his presentation through? May I request Dr. Namboodiri to run his presentation and take his presentation through? May I request Dr. Namboodiri to run his presentation and take his presentation? Dr. Namboodiri,
Yeah.
are you able to see your presentation now?
Yeah. Oh, yeah, I can. But can you make it full screen? Is it possible?
Please go ahead.
Full screen right now?
Can you see the full
Okay,
screen now?
fine. Yeah. That is true. I mean, I can see it properly. Can you hear me properly?
Yes, sir, we
Can
can
you
hear
hear
you.
me? Yeah. So, sorry for the initial trouble. I will be discussing the importance of yoga in the cardiac disorders, especially regarding hypertension, diabetes, and other things. I'll be talking only the basics, how body and mind are interrelated. In this era of pandemic, I don't have to overstress on how stress plays an important role in day-to-day life. The prevalence of stress is increasing the community with a multitude of reasons. And stress can be defined as the human response to many sorts of noxious agents and threats. It could be physical, chemical, emotional, or environmental stimuli. And we already know that stress can exacerbate or cause many common medical conditions. Way back in the first half of the last century, 1950s, a psychoanalyst from Budapest, Hungary, coined the term uh, psychosomatic disorders, where he put 8 to 10 disorders that can have a mental basis, a basis of mind as the cause of physical problem. Can I have the next slide? In fact, many of these conditions can have, many physical conditions can have a basis of abnormalities in the mind, mental stress as the common problem. And this was this was described more than 2 millennia back by Patanjali in Yoga Sutra, who is known as the founder of yoga, the father of yoga, if you can call. And this is the Pancha Klesha is based upon 5 problems that can affect the mind, that is lack of awareness, sense of egoism, attraction and repulsion, that is raga and dvesha, and abhinivesha, that is desire. So avidya, asmita, raga, dvesha, and abhinivesha, the panchakleshas can result and in turn translate into some physical problems. This was by Patanjali, and asmi means myself. Based on that, the definition of yoga, that is Chittavritti Nirodha Yoga, assumes major significance. That is controlling one's own mind, that is Chittavritti Nirodha. And in Yoga Vasishta also mentioned Manaprasamanobhaya Yoga, who has got the skill to control one's own mind. That is the definition of yoga. And the yoga as a therapeutic modality has become accessible to many people, and it is cost effective and not associated with any major side effects, though the effect is not great, but in certain physical conditions, it can have significant impact by controlling the mind and its cascading effect on body. Can I have the next slide? The 8 components of the yoga, as mentioned as the Ashtanga Yoga, Patanjali mentioned himself that time. That is the attitude towards environment, attitude towards ourselves, and physical postures, restraint of breath or breathing exercise, withdrawal of the senses, concentration, meditation, and complete integration. Yama, Niyama, Asana, Pranayama, Pratyahara, Dharana, Dhyana, and Samadhi. Can I have the next one? The literal meaning of the Sanskrit word yoga is union. It essentially means union of body and mind, which improves physical, mental, and spiritual well-being of an individual. But how does it affect the cardiovascular pathology? Stress, we know, stress is an important factor in life, and that can cause a neurohormonal activation in the body. It can activate the sympathetic nerve system and also can result in release of ADH. The Sankhya Yoga of Bhagavad Gita clearly mentions that Thyayado Vishayan Pumsa Sangaste Shubhajayade Sanga Sanjayade Kamad Krodho Vijayade Krodat Bhavadi Samoha Smriti Vibrama Smriti Pramshal Buddhinasa Pranasiri. That is the way it results in a cascade of physical problems resulting from mental stress and other mental disorders. So this can result in a sympathetic nervous system which can exacerbate the existing conditions like heart failure, acute myocardial ischemia, coronary vasospasm, and arrhythmia, and also problems like hypertension and insulin resistance. The cascade of neurohormonal activation results in an imbalance between sympathetic and parasympathetic systems in the autonomous nervous system. Next slide. So this imbalance, can I have the next slide? This imbalance results in a dominance of sympathetic system. The physiological effect of yoga is twofold. One, by decreasing the catecholaminergic release and activity resulting in lower blood pressure and heart rate, and simultaneously by increasing vagotonia, that is during meditation, the parasympathetic nervous system is activated. So this renewed equilibrium, that is a stable equilibrium, a balanced sympathetic parasympathetic axis results in well-being of human body. Next slide. So this has been, next slide please. So this is what Bhagavad Gita defines. That is samatvam sarva uchyate, yoga uchyate. That is the samatvam between sympathetic and parasympathetic that results. We had multiple trials, both randomized and non-randomized, in hypertension, heart failure, CAD, insulin resistance, and obesity, which had clearly shown that regular practice of yoga, particularly when combined with other lifestyle modifications, can induce desirable effects on blood pressure, glycemic status, body mass, and anginal symptoms. Next slide. Next slide, please. But is the available evidence robust? Subsequent speakers will give elaborate idea on how yoga is effective in different parts, different aspects of cardiology. But in short, most of the studies conducted had been in small number of patients. There had been major differences in the type of yoga practiced with or without meditation. And many studies had subjected the treatment arm to other lifestyle modifications also. Next slide. So the available evidence may need a better interpretation in this regard, but not everything need not be evidence-based medicine. When you come to the evidence, there could be some publication bias. There may not have true control in yoga in clinical trials because double blinding is nearly impossible. And most of the RCTs on application of yoga in coronary heart disease, the substrate wherein it was studied in detail, included mainly male Indian patients. And the clinical supervision and the training was not uniform across these trials. Choice of style, choice of techniques, dosing, all could vary, and it demands more trials in this regard to have better evidence. Next slide. There are many different choices of styles of yoga practicing. Iyengar yoga, Hatha yoga, all based upon physical exercise and physical postures, and many other different types of yoga. So that also needs to have uniform application when you apply in medicine, treatment in modern medicine to generate robust evidence. Next slide. Next slide, please. So choice of techniques also would be important. Individual versus group practice, specific postures, pranayama, meditation, or combination or sequential application of these techniques. Next slide. In this aspect, we need to go back to what our ancestors taught, what Patanjali, Bhagavad Gita, and Yoga Vasishta mentioned. There could be a conflict of application of yoga. It is inherent in that. When you deal with mind and physical disorders, body, some may give more importance to mind, some may give more to asana. This was inherent even in the initial phase of yoga. Manasa yat kridam kridam Rama nadu sharira kridam kridam. That is what Bhagavan Sri Rama was told by Vasishta, which essentially means what you do with your mind is the real thing, what you do. What you do with your body is not essentially the correct thing. The second line is quoted in Bhagavad Gita as well. But when you give more importance to body, it is Sthira Sukham Asanam. That is what Yoga Sutra told. that is Tirasukham asana, and similarly, Bhagavad Gita mentioned Samam Kaya Shirogriva. All this give importance to physical postures and involvement of body, physical exercise, postures more than the mental meditation and other aspects. Next slide. Yeah, this is so concluding. The regular practice of yoga, particularly when combined with other lifestyle modifications, can induce desirable effects in many physical conditions like blood pressure, glycemic status, body mass, and angina symptoms. Essentially, the lack of side effects and a favorable cost-benefit ratio makes it a desirable ancillary tool in the management of subjects with the cardiac diseases. We need more larger RCTs and essential other trials to establish its exact role in management of cardiac risk factors and cardiac rehabilitation. And with this introductory remark, may invite the other speakers, Dr. Brahma Nanda Sharma, to give his views on yoga and its relevance in preventing coronary artery disease, controlling the epidemiology of CAD in Southeast Asia. Thank you.
Dr. Brahmanand, you have shared your entire screen. May I request you to share only your application? You'll have to stop sharing and go into sharing again and select application.
Am I ready?
Yes, sir. Can you please share your screen?
I just did. Okay, share your screen. Okay. Yeah, he told me I got hold. I can do it now. Am I ready now?
Sir, share your screen. You have to stop sharing and share again.
Okay. Okay. Can you see it now?
So you have shared your entire screen. May I request you to share application alone, your presentation? The option that you have shared is entire screen.
Oh man.
As Dr. Namboodiri said, take a deep breath.
Is it okay now?
No, sir, you haven't shared your screen yet.
No. What do you want me to do? Do you want me to share the screen or not?
Yes, sir. We want you to share the screen. Please click on the share screen option.
Yeah, I'm sharing now. Okay. All right.
Now select application window.
Okay.
You will have three options: entire screen, application window, and Chrome tab.
Yes. Which do I do now?
Go into application window.
Go in the window.
Application, yes.
I don't see application window. I just see window.
Go into window, sir.
Okay. And
Do you see your application?
I don't see any. I just see an entire screen window on Chrome tab. So where do you want me to click now?
May I suggest that Dr. Dibbendhu Khanra goes first, and then we will troubleshoot your screen share and come back to you. Is that okay?
Yeah, somebody called me from Tennessee. He already cleared the. He helped me out, but I don't know why you want me to repeat this again.
Right, sir. I will invite Dr. Dibbendhu to give the presentation in the meantime. Go ahead, Dr. Dibbendhu. Dr. Dibbendhu, please go ahead. Dr. Dibbendhu, we can hear you.
Hi there. Should I run my presentation now?
Yes, sir. Please do.
Oh, okay. Just a moment. So let me share the screen. Okay. Let me go to the top. So am I audible and visible? Can you see my screen? Okay.
Yes, we can hear you and we can see you.
Okay. Yes. Excellent. So first of all, I would like to thank the organizer for allowing me to present this topic, the important topic of AF and its epidemiology and how it's becoming a global pandemic. And it's my pleasure to speak in front of the chairperson, Dr. Namboodiri, and my other speaker, Dr. Sharma as well. So first of all, I'd like to give a brief introduction of myself. So I did my cardiology training from India, and I came to UK to do the fellowship in electrophysiology and devices. And in the Western world, when we see the abnormal rhythm of the heart, the arrhythmias, the 50% or rather more, the two-thirds of the arrhythmias are actually atrial fibrillation. And as the populations of the Western countries are quite aged, so we see lots of aged population with plenty of atrial fibrillation. So AF is really a big burden in terms of cardiovascular disease. So what we're going to discuss today is that, first of all, I would just touch a brief on the overview of AF, that what is that and what are the risk factors and how do we treat it. And then I'll discuss about the global epidemiology of AF and what is the status of AF in India, and how and what is the gap of this Western and Asian context of AF. And then I will also briefly talk about the role of yoga meditation in atrial fibrillation. So, as you know, the atrial fibrillation is a form of irregular heartbeat. So, patients actually complain of fluttering of their chest, kind of palpitation, and it is the commonest form of arrhythmia in the Western countries. So the important aspect about AF is that it's kind of an iceberg of the disease, because the AF patients which we diagnose by means of ECG or by palpating a pulse, that is a snapshot of the entire problem, because lots of subclinical AF actually exists, and unless we screen the AF, the patient properly, the diagnosis of AF would not come at all. And it's not only a problem with the rhythm, and it can have serious complications which could lead to a poor quality of life, fatigue, heart failure, stroke, and even death. So the most important consequence of AF is the patients with AF has a higher risk of stroke in comparison with the normal population. And when we talk about the AF, it depends on what is the duration of that AF, and depending on that, we can classify as paroxysmal, persistent, permanent AFs. So age is the single most common important risk factor for AF. If we think about people of age less than 40 years, the chance of AF is only 1%. Whereas the when the age becomes more than 65, we can have at least 8 to 10% people with AF, and when the age is more than 80, there is almost 20% chance of AF. Obviously, the females, hypertension, diabetes, CAD, all these are conventional risk factors. But the few important risk factors which are being more recognized in the contemporary world is obesity, and also the association of obstructive sleep apnea with AF is remarkable. And as Dr. Namboodiri already mentioned, that stress is an important aspect. It can not only lead to coronary artery disease, but can also give rise to the disbalance between the sympathetic and the parasympathetic system, and can give rise to AF. So when we talk about AF and the risk of stroke, we actually calculate score called Chadva's score, and there we actually see a few parameters in terms of heart failure, whether the cardiac function is less than 40% or not, the hypertension, age, diabetes, previous stroke, any other vascular disease. So this calculations we do to have an idea that what is the risk score of the particular person, and any score more than one needs some kind of blood thinners in the form of anticoagulants like warfarin or the newer anticoagulants. Talking about the treatment of AF, the rate controlling strategy revolves around the beta blockers mostly. However, dioxin also has some role. However, it's not very suitable for the active lifestyle. There are also problems with the beta blockers that people with asthma cannot tolerate beta blocker well. In terms of antiarrhythmic drugs, amiodarone is the commonest one which are used. However, it has serious consequences in terms of skin pigmentation, cataract, thyroid issues, lung problems. So what we see in the practice in UK is that whenever we want to prescribe amiodarone, we tell them the all the complications, and it's up to the patient that whether they want to start this amiodarone tablet or not. And most of the time, I would say 2/3 of the patient do not want to start amiodarone or cannot continue amiodarone. So ultimately, they resort to the ablation therapy. In terms of treatment, basically the paroxysmal AF, which we diagnose, basically the earlier we diagnose is better, and earlier we treat, the lesser the consequences. So paroxysmal AFs are mostly treated with the pill in the pocket therapy, like with the flecainide. However, if the patients do develop heart failure, palpitations, compromising quality of life, low EF, in that case, we first try cryo AF ablation, because that is a faster way, and it requires less skill and less setups. Also, the cost-effective analysis has shown that the cryos are cost-effective in than the RF ablation. However, when the patient's AF turns towards early persistent or permanent AF, in that case, again the ablation becomes the primary therapy. However, because of the waiting list of so many AF patients who needs ablation, we tend to do a cardioversion first, and we try to give a patient a better quality of life and attempt to go back to sinus rhythm. However, eventually it recurs and comes to cardio or RF ablation. In terms of success, despite all the technological advances, still the success rate would be 60 to 70%, most 80%. So 1 in 5 patients will come back with AF in 5 to 10 years of time, and he or she will need another redo ablation again. So that's the treatment protocol for AF. In terms of which one is better, because in terms of Indian perspective, basically, so cryo AF ablation is still not available in India, but it's going to come up probably in next couple of years. The important thing about cryo is that it requires less skill and less setup. However, RF ablation is a more complex procedure, and the complications could be more in unskilled hands. So the problem with RF ablation for AF is that it's a time-consuming procedure. Usually, we do 2 to 3 ablations in a day. However, with the advent of pulse field ablation or the electroporation, the AF ablation could be ultra fast, and it appears that it is going to be the future solution for AF. Now, talking about the epidemiology aspect, basically, which is my primary topic. So AF is a global pandemic, and the incidence and prevalence of AFs is increasing with in great deal. As we know that almost more than 3 million people in US are living with AF, and in terms of United Kingdom, almost 3% of the population has AF. it appears, I mean, it is projected that almost 6 to 12 million of people in US is going to have AF in 2050, and almost 18 million people overall in Europe will have AF. So definitely it's a global burden, and as the population age is growing, the prevalence is going to increase more. Now, is it really a problem of the Western world? So if we see the map, we can see the prevalence of AF is quite more in the North American and European countries, in comparison to the Asian and Indian populations, and that is something which we should keep in mind. We'll discuss more about it. And when we look at the low economic countries, the problem with AF is still increasing. However, the increment is less prominent than the Western world, but still the problem is there. So coming back to the Indian scenario, so there are few cross-sectional studies on randomly taken patients. So for this in this study, so the AF was diagnosed by a single ECG only, and the prevalence of AF was found to be very low, only 8 out of 4,000 patients. And if you see, the commonest cause of this AF patients are rheumatic heart disease, which is not a problem of the Western world, and they tend to be quite young, and many of those patients who actually require anticoagulation, but they're not taking any. So this is a small study. As we know that the life expectancy of Indian people are less than the Western world. However, the life expectancy is increasing over the years. The important thing to remember is that in the Indian populations, the AF seems to be start early, after 45 years of age. So the Chatwas coding and the role of anticoagulation might need to be started at an earlier age for Indian uh, population. This is another small outpatient-based study, which again showed that the diagnosis of AF is quite low, because the AF was diagnosed by a single pulse study or an ECG. So it's one of the large AF registries, the IHRA's AF registry, very important one. It incorporated 24 hospitals, almost 1,500 patients, and it again showed that the mean age of the AF Indian patients are quite low, and rheumatic heart disease is still a large proportion of the etiology. Uh, Non-rheumatic valvular heart disease was found to be only 5.5% in this registry, and most of the patients of AF are treated with anticoagulation in terms of vitamin K antagonist. The use of newer anticoagulations are quite rare. It also showed that heart failure is the commonest cause of death in the AF patient, and also the hospitalization is also commonly due to heart failure. So this registry followed up the patient for 1 year, and it was found that most of the patients turned into a permanent AF from a persistent AF. This is another registry, the Kerala AF registry, which Dr. Namboodiri was a big part of it, and it took patients from 53 hospitals in Kerala. Again, the important thing is that the median age is 65, which is on the lower side in comparison to the Western population. The heart failure, so almost 27% of those AF patients did have heart failure. 15% did have a episode of stroke. The important difference from the IHRS AF registry is that the non-valvular AF was 75%. So that means that rheumatic heart disease is still an important cause of AF, but the non-valvular AF still exists. And in terms of anticoagulation, most people were on vitamin K antagonist, and the use of NOACs were actually low. And again, in a 1 year follow-up, 13% patient died. So there's a good proportion of patient with AF dies after being diagnosis. The cause of death could be heart failure or any other arrhythmia. Also, in 1 year follow-up, 70% patient has to be hospitalized due to any of the reasons, either stroke or heart failure, arrhythmias, or ACS. So this is important because the diagnosis of AF comes with its consequences. So the earlier we can diagnose AF, earlier we can treat, the better result will be found. The other important aspect is that the question that why AF in India is low, why the prevalence is low. So it is arguable. It could be some genetic polymorphism which is there in the Caucasian group in the Western population, but still it's believed that the screening of AF in India is low because the subclinical AFs are not diagnosed if we diagnose AF by an ECG or by a pulse. And as you can see that subclinical AF is also a major cause of stroke. So monitoring is important. As you can see that single ECG diagnosis of AF only reveal 1.5% of the AF. However, if we can monitor them for a prolonged period of time, we can pick up more and more AF patient, and that thing is still not practiced in India. So how we can pick up the AF patient? So as the India is getting digital and the IT is becoming more prevalent in India, so the advent of this Apple watches and smartwatches are important because they can give a real time assessment of the heart rhythm, and it can send signal or an alarm to the people that your heart rate is irregular, probably AF. There are also other gadgets like the watch BP, the Cardia Alive Cord handheld device that it can be given. The patient can hold that device close to his heart, and ECG rhythm strip can be recorded in his computer, in his mobile, and that can be transmitted to the doctor who can diagnose that is it AF or not. Also, the geo patch is also commonly utilized. So the important message is that we have to screen more to diagnose more AF. Also, there are other tools like implantable loop recorder, which can be implanted. Again the cost is the issue because the cost of an ILR is as equivalent to a single chamber pacemaker. There are knowledge gaps about AF because many patients know that AF is a cause of stroke, and the blood thinner has to be used, the INR has to be checked. But many people do not know that AF can cause heart failure as well, and AF could be subclinical as well. So those knowledge gaps still exist, and we need to make more effort to uh, spread the awareness of this disease. In terms of Indian or Asian context, the uh, utilization of anticoagulation in AF is still low if we compare it with the Western world. So how can we improve screening? So the Smart India is a new study which is recruiting patients now with Alive Cord. So with that device we can monitor the heart rhythm, and we can diagnose AF more efficiently. The important thing is that as there are in I mean as the population of India is big, so the burden of AF is estimated to be big as well, and we cannot do long term screening for all the patients. So the another way to identify progression to AF is to do some artificial intelligence guided ECG modeling. So either it could be done by the clinical indicators, or it can be done by simple ECG. How we do that? So whenever if you can take a 10-second long ECG of a patient in the sinus rhythm, and when the patient goes to AF, if we can take another 10-second long ECG for the same patient, and we can compare these ECGs and find out the important machine learning abilities to know that which of the patients will go to AF, so just for a single ECG analysis. So this is important study which came out in Lancet in 2019 from the Mayo Clinic. So they studied almost 200,000 patients ECG, and followed them up with another ECGs, and they have found a few machine learning parameters with those ECGs. And when they compared those AI guided ECG with the prediction scoring system, they found there is a good comparison. But the important thing about AI guided ECG is that you don't need to know about the patient clinical parameters. So with a single diagnosis of ECG, we can know that what is the chance of that particular patient to go into AF. Say for example, if the score is more than 50, that means incidence of AF is 20% in 2 years and 50% in 10 years. So with this prediction model by a single snapshot AI guided ECG, we can diagnose more people at a risk of AF, and we can start anticoagulation on them. However, this strategy is not it's still debatable. We need to have more evidence for that, but definitely it's something to look forward. So managing in AF has different problems which we discussed, because the true epidemiology we don't know because the screening is poor. The rheumatic problem seems to be the major cause of AF, but still the non-valvular AF are important and are growing. The availability of the smartwatches and the AI-guided ECG should come forward. The anticoagulation should be used more as needed. The use of NOACs are definitely limited by the cost and availability. The ablation of AF is important and is going to be more important in the next decade in India. And again, the costs and the centers will be an issue in the future. The cryo balloon will probably be launched in India in next 1 or 2 years, and then more and more patients of AF could be ablated. However, the Indian patients should know the limitation of an ablation, because AF is a recurrent progressive disease, so it can come back after 5 to 8 years of time, and the patients might need a redo population. So managing patient expectation is also important. So we know the limitations of the treatment for AF, whether it is a medical therapy or an ablation therapy. But still, there should be something more affordable, available, and a safe method which normal people can implement. And yoga and meditation could be a new way. It may not be a replacement of the available therapy, but definitely it's something to supplement on. So how does it act on AF? Because it has been seen that yoga actually reduces the sympathetic activity and improves the parasympathetic tone and creates a balance between these two systems. Um, Dr. Namboodiri already explained the pathophysiology mechanism well. I'll just touch on them in brief. So I'm not going into that. So one important aspect is the heart rate variability, and with the yoga and meditation, it has been found that the heart rate variability is low. The overall heart rate comes down with the tuning up of the parasympathetic system. So there are a couple of important studies of yoga on AF, which I would like to just share. So first one is a yoga Maya study, which is done by Dr. Lucky Reddy from Kansas City. So it's a non-randomized study. It's rather a case-control study where almost 50 patients had yoga and relaxation therapy, and the 50 patients had were just control. And it has been found that the episodes of symptomatic AF, asymptomatic AF, both were low. Also, symptomatic non-AF cases, that means the other arrhythmias, are also low with yoga. And not only the electrical burden came down, but also the depression, anxiety, and also came down with yoga, and the mental health improved, and the overall blood pressure is also better control with the yoga population. So definitely yoga helps, and it's also evidence based now. And the question is that which patients we should try this method. So in this particular study, it was tried on the paroxysmal AF. um, but I'm not aware of any study where it has been tried on persistent AF as well. When I was in AIMS, we were conducting a study on rheumatic heart disease patients with AF, and we were trying yoga with the population in a hypothesis that probably it would help controlling their heart rate better. So how yoga does all those improvement in the cardiac function? So it's called as a psychoneuroendoimmunological. So it acts in multiple level. In the at the level of brain, it acts because there should be a balance between the autonomic nervous system, the parasympathetic nervous system, and the adrenergic sympathetic system. So the yoga acts also in the amygdala and the periaqueductal gray and the singular gyrus, where the hypopituitary axis stays. And also it tones down the parasympathetic activity. It also acts on the insular hippocampus, where the overall awareness increases. It's also act as a psychological level, and the depressions are less because the yoga acts as the locus coeruleus and the diaphonucleus, where is the site for the release of norepinephrine and the serotonin. It also acts on endocrine level, and it improves the neuroplasticity, and also it takes down the hypothalamic pituitary axis. It reduces the glucocorticoids and its receptor. At molecular level, it reduces the inflammatory markers. At cellular level, it reduces the inflammatory cells. And even at genetic level as well, yoga may act as a epigenetic uh, modification. So there are various ways it has been found in the studies that it can affect our mind, body, and heart as well. The last study which I'll just talk about in brief is the only study which I could found is a randomized study which compared mostly 40 patients with yoga and 40 patients without yoga. And again, they have found that the overall heart rate control is better with yoga. So is the control of the blood pressure, and also the quality of life is quite well achieved and better achieved with yoga than without it. So, just to summarize, so AF is still underdiagnosed in India, and it needs lots of screening. And the better way to diagnose the AF populations is to do an artificial intelligence guided ECG. The non-valvular AFs are underestimated. The AF can cause heart failure and as well as stroke, so it's important to start anticoagulation if indicated. AF can also have a poor quality of life. So controlling of AF with medications or ablation is important and is going to be more important in the future in India. Ablation of AF is a future need in India, and cryo will be definitely a hit when it comes to India. And yoga and meditation can be utilized. Again, the which subset of patient who will need yoga meditation is still debatable, but still with the evidences we have, we can definitely advise the patient to do some yoga. Thanks for the patient hearing. Thanks for your time. I'll stop here, and I'm happy to take any questions. Thank you.
Dr. Dibbendhu, a great talk. And in fact, before we get into the next talk, while Dr. Sharma is preparing his slides, we'll have one or two quick questions and then we'll have detailed discussion later on. Dr. Sharma, are you ready with the slides?
Yeah, yes, I'm ready.
Okay,
Yes, Dr.
please
Sharma
go
is
ahead.
ready with the slides.
Then we can have discussion on these two talks together at the end of the session. Dr. Sharma,
Okay,
please.
can you hear me and can you see my slides? Hello?
We can hear you clearly, but slides are yet to come. Yes.
Now you can see the slides too?
Yes.
Okay. Okay, I'm sorry for this glitch and a lot of back and forth. I'm Dr. Sharma, as you know. It is a great pleasure talking to you this morning. Appreciate the organizers for giving this chance. So my story is actually your story and every family's story. So I always talk about this South Asian epidemic by giving an example of a story of my friend, actually. And this is a true story, which still haunts me. This is a 45-year-old physician of South Asian origin who was actually jogging in the park where I live. He played tennis every day. While jogging in the park, he collapsed. 45-year-old young man, a jogger, collapsed. And then he was taken to the hospital where I work and was resuscitated successfully. Of course, he came to my cath lab. And next slide. Next slide. Can you go to the next slide? Anjali, can you? Okay. Anyway, go back to the slide. Okay. So his electrocardiogram, as you can see, some of your physicians, is very dramatic and very scary. You can see tallest elevation in the anterior leads, and this is a STEMI. With the new definition of a heart attack, we have to classify them as STEMI or non-STEMI because that decides the course of action, and the time is the muscle, and time is the life. So this is a classical STEMI. Next slide. So you can skip this slide. Next one. Next one. Yeah, just play this. Okay, so it's not playing. Anyway, so cardiac catheterization was done, and he had a proximal tight LED, and he was stented. So he came to me after resuscitation, rehabilitation, and everything else, and he asked me 3 questions. You know, what happened to me, and how can I protect my kids from having this acute heart attack and cardiac arrest at this young age? So the story is not new. This is a story that is repeated in almost every city in America and USA, and I would say globally among South Asian diaspora. As you know, South Asians constitute about 25% of the world population, but they account for about 60% of the cardiovascular burden. So the most of the cardiac heart disease and heart attacks are not happening in Europe or America. The major burden of the cardiovascular disease, believe it or not, ironically, is in low and poor countries like India or South Asia in general. So what is the mystery about it? And we don't know what it is, actually. We don't know whether this is a genetic, this is a metabolic, epigenetic. So first hypothesis that was proposed about this mystery of South Asian heart disease is called a thrifty and drifty gene hypothesis. And the hypothesis postulates that because of over millennia, we were living in a population and starvation, so our genes have somehow downregulated. And suddenly we have explosion of the caloric metabolic overload, and that's why we are into this crisis of prediabetes and diabetes. This is the thrifty gene hypothesis. Next slide. Anjali, can you go to the next slide? Okay, so this is just to show you that before we become a full-blown diabetic or a pre-diabetic, there is a natural progression from insulin resistance to pre-diabetes to diabetes. And somehow, this is another unique thing that for compared to Caucasians or Europeans, we tend to become diabetic or pre-diabetic at a lower BMI, at a lower body weight. So our curve is much more steep. This is something we need to understand. and realize and detect our early stage of insulin resistance early on, and not be fooled by our body weight or our belly circumference or our waist circumference. So this is something very unique about us. We are a unique phenotype, something that we have to bring home to our South Asians, that despite normal body weight, despite normal waist circumference, you can still be prone to pre-diabetes and diabetes. And that is the holy grail of South Asian. This is how the whole thing starts. Now, if you go into metabolic pathways, how this all leads to cardiovascular disease, on one side is insulin resistance, and that has another South Asian paradox: low HDL, obesity, hypertension, glucose intolerance. This is a metabolic milieu that goes together. And then we have this leuko kines and cytokines, adiponectin, leptin, TNF alpha, and prothrombotic plasma activator inhibitor, whole milieu of cytokines and molecules that predispose to endothelial dysfunction, nitric oxide problems, and then, of course, markers of inflammation leading to atherosclerosis, thrombosis, and a heart attack. So from one end, from insulin resistance and mild obesity, metabolic dyslipidemia, prediabetes, the whole cascade predisposes to the endothelial dysfunction, which is the earliest marker or pathogenetic pathway for full-blown cardiovascular disease. Next slide. Now, that is one hypothesis, metabolic hypothesis. And then this is another hypothesis. Sometimes you find out that the inflammation is also playing a role, despite being normal body weight and no insulin resistance. Some people I have seen in India a long time ago, when they have a massive STEMI, we go in the cath lab and find out that all they have is a thrombus, just a pure thrombus. And by the time you give them TPA or streptokinase or even heparin, they recanalize. And the coronary angiograms looks clean, except some plaque and some haziness. So we also surmise that this is purely inflammation causing the thrombosis. So that is also seen in young population in India. So there's another hypothesis, inflammation. Next. So when he came to me, I talked about this, that this is a heart attack. So how can we prevent this whole tragedy or travesty in our kids, in ourselves, in our second generation, third generation? Next. So we thought there was a mystery about genes or our biology or our metabolism or the size of our coronary vessels, but Salim Yusuf, the famous cardiologist from McMaster, Canada, he did an inter-heart study, trial of strokes and MI. He found out, to our surprise, that no matter whether you are Asian or American or Europeans, the basic bottom line risk profile is the same. So he compiled all these risk factors, and he could explain that 90% of the heart attacks in South Asians are also because of the same problems that we see here in Caucasians in America and Western population. So there's a South Asian paradox that despite low BMI, we have a high inflammation, high resistance of insulin and diabetes, and that leads to pre-thrombotic state and cardiovascular disease. Next. Next slide. So this is just to show you how this whole thing starts in our blood vessels in a small plaque, fatty streak, and fatty streak then cause the lipid peroxidation, and lipid peroxidation causes inflammation. And with the inflammation, at some point in our life, early morning when we are mad or we are under bad spell, there's a rupture of the plaque, and it's like a volcano in our blood vessels that leads to platelet aggregation, what we call a white thrombus, and then red thrombus, and the whole disaster happens. If we are lucky, then we can recanalize to some degree. We end up with a non-STEMI, but if there's no collaterals, everything is against us, high pre-thrombotic state, we have a full-blown coronary occlusion and a massive heart attack. Now, this is a biological progression. Endothelial dysfunction, I talked to you, it predisposes to inflammation, to oxidation, and of course, plaque instability, plaque rupture, and coronary thrombosis. Next. So in India or here, especially, we don't have a data of our own in India. That is one of the biggest problem, but we extrapolate the data from the European or Caucasian population, and we tend to calculate 10-year risk. I think that is a misnomer. That is a flawed. We need to think about 30, 40 years. So we need to discuss about the lifetime risk. That is something we need to adopt. So there are a few things that I will be talking to you as to assessing the risk and predicting the heart disease in South Asians. We have to do something different. One of them then is this, that we need to really pay attention to our lifetime risk, because 10-year risk may be low, and that can make us complacent, and we can stop doing things that we are supposed to do, and then we pay the price for that later on. Next. So there were scorings were done, since 1960s, when we found out the risk factors. The scoring system came, in America, then European score, and then the scoring started scoring themselves. But we cannot extrapolate the scoring system from Framingham, Massachusetts to Chennai or Mumbai. We have to have our own. And that's what the problem is. Even with the guidelines, we are always underestimated. If you see my story of my friend who collapsed, his ACC pooled cohort risk score was 3.1. As you all know, there is an app that you can calculate the risk for a heart attack in South Asian or European. But there's a drawback is these data are derived from the Caucasians, and we tend to extrapolate to South Asians. Does not work. It always underestimates, and that's what happened to my friend. He had ACC pooled cohort equation of 3.1%. Based on that, he did not even need a statin. He was not put on a statin by a local doctor who had no idea that South Asian heart disease is different. And that's what happened to him. So just to highlight you that South Asians risk scoring by the new ACC model does not apply. It underestimates. So you have to think of something else. And that's where the question of coronary calcium score comes. Next. So there's a detection gap in the heart disease in South Asians. The conventional models derived from European population do not apply. We have to have our own, but we don't have yet. We are working on it. And that's why this detection gap is a very big problem. Half of the heart attack in South Asians happen because they don't even know. Their cholesterols are normal. It's like a bolt from the blue. So how can we detect this disease early so we can protect, predict, and prevent and manage it? That is our challenge. Next. So when you go for a testing, these are the things you need to ask as a patient in America, Europe, or in India, if it's available. Don't be satisfied with your anthropometric, diet, weight, and height, and blood pressure. Look for LPA, look for HDL2, look for CRP, because these are the basic things that can tell you that you are much more prone and can also help you to stratify your risk beyond the conventional checkup in your doctor's office. I always check LPA in my patients in a CRP. And beyond that, there's a new test that I want to talk to you. If you don't remember anything from this talk, please remember this. South Asians are not very well detected by the conventional scoring and profiles. So there's one test that you need to do, especially if you're intermediate category, and that's called a coronary calcium score. Now, this is not a CT angiography. This is not coronary CTA. I'm not doing that. I'm not recommending that. In asymptomatic population, all you have to do is an $80 coronary calcium score. And coronary calcium score will actually further stratify your risk and also put you into the right category, whether you are really high risk or low risk or intermediate risk, much more with the incremental value that you get from your score. In every South Asians with a family history, I would highly recommend that you get a coronary calcium score. And it will also really help you to find out whether you really can take an aspirin, whether you could take a statin. So it not only helps you to detect your risk, but also helps you to know whether further treatment is really necessary for you. Just like we go for a breast cancer, you do the mammogram. You go for prostate cancer, you go lung cancer. But in cardiology, I don't know why we depend on the scoring by risk factor. It's about time we just go and take a picture of your heart by CT scan and find out how much plaque you have. And by all the measures, by all the standards, coronary calcium score was the outstanding discriminator. More than your body weight, waist circumference, carotid intima, all other markers, biological or chemical markers, coronary calcium score predicts your risk of a heart attack much more objectively, short-term, long-term. So that is something I would recommend. And this is based on the MESA study and also new study, Masala study that you may have heard. Masala is the first South Asian cohort in America. Dr. Khanra is doing it. And all this data from ethnic study are also supporting this concept of coronary calcium score in every South Asian. that will help us to stratify our risk much more accurately and also alert us to start preventive therapy early on to protect and prevent a massive first heart attack. Next. So the dual approach is recommended nowadays in most of the Indian South Asians, unless you are a very, very high risk. But the dual approach is the risk factor calculation, but also please get a calcium score. That will give you a better idea where you stand. Next. So there are two studies going on. One in UK is a lollipop study. We don't have much prospective studies for South Asians. As you know, we are not good at doing good studies, and we don't have time and patience to do long-term like a Framingham study. It is about time. We have a Framingham type of long-term South Asians, but there are people who are doing it. One is Dr. Khanra Masala study in USA, and this is lollipop. So we'll wait for the data for this study. But in the meantime, we are collecting more information. But there is Dr. Amikera. I don't know you heard of him. He's a geneticist and primary preventive cardiologist in Massachusetts, Harvard Medical School, and he just is hot. This information is just hot that he has been able to put the South Asian genetic score based on the genes that will predispose us to a heart attack and heart disease. And he's recommending every South Asians, he has a registry to get this test done. And this will add further, in addition to your risk profile, ACC risk score, then your calcium score, and now this is a polygenic South Asian risk score. So all the three risk scores will actually further stratify and be more accurate in predicting. I'm going to get my test done next week, actually. We are going to invite him to give a talk. Amikera, he's a preventive cardiologist, came out with this model a few months ago and is promoting very highly. You can hear his talk on American Heart Association. So in order to find out early on who is really highest of the highest risk, don't count on your risk score, go for calcium score. But even beyond that, especially if you have a family history of sudden death, please get your genetic score. It's only $300 test. That will give you a much more enhanced incremental value that will also alert you, shake you up to get things done. And whether you can fix your genes or not, but the data show that even if you have a genetic predisposition, you can do all the preventive therapies and you can reduce your outcomes based on lifestyles and statins and aspirin. This has been shown. So genes or DNA is not your destiny. Epigenetics, your behavior, your lifestyle, and your efforts, you are your destiny, not your genes. Even if you have a bad baggage from the family, you can also modify the genes based on the epigenetic study. And these are the data from that. In every group, low risk, medium group, or high risk, you can reduce the risk of heart attack, even if you have a bad family history. Next. So just to summarize, the same thing, ABCDs of prevention, risk of aspirin. Now, aspirin has become controversial lately because of the data, but still people who are high risk, like South Asians, I would still recommend, unless you have an obvious risk of bleeding, low dose aspirin is good as long as you are below 70 and you're not bleeding. Exercise, I cannot talk enough. We could talk about exercise for the whole hour. Need to do it. Diabetes are on nemesis. We run the risk of diabetes early on, pre-diabetes, insulin resistance. We need to be very aggressive. Our hemoglobin A1C numbers are much lower than the usual. And we also have new therapies for diabetes, SGL2 and GL1 inhibitors that are primarily cardiovascular drugs, even though they were started as a diabetes drug that will prevent hospitalization, heart attacks, and heart failure. Diet, vegetarian diet is no good, especially if your vegetarian diet includes a lot of ghee and sugar. We need to go for plant-based diet that has the best data, or DASH diet, and we'll talk about that sometime. Cigarettes, no. Cholesterol profile is different. We are not a problem with the LDL unless we have family history. Our problem is low HDL and high triglycerides. That's our lipid profile background, which is especially different. So our problem is low HDL and high triglycerides, but we need to take statins. They do work like any other population, and we need to start on a high dose, and our numbers should be lower than the rest of the Caucasians. And of course, the blood pressure. Now, blood pressure definitions have been changed, as you know, and 120 to 129 is normal. Anytime you go to 130, 139, you already have hypertension. And so we have to be careful that the numbers have been changed. And so that we have to go early on and detect and manage our pre-hypertension and diabetes very aggressively, because diabetes is a cardiovascular disease. Diabetes is not a separate entity. We use diabetes as a cardiovascular disease because this is our pathway to develop diabetes most of the time. So the diabetes and hypertension are part of the whole syndrome, and a holistic approach is better than anything else. Next. Okay, so that's the end of my discussion. Any questions, I'll be happy to answer.
Yeah, great talk, Dr. Sharma. You have clearly mentioned the risk factors in South Asian population and the ways to control clearly. I have a few queries. The first thing, with India-Heart study and Masala trial, we have clear evidence that risk factors play an important role. We have identified a few of them as well. But apart from diabetes, you have diabetes as the one of the risk factors already identified. Then the luminal size of the coronary is another one, and the dietary habits you already mentioned. So which one of them is the most important? Is it still diabetes and the metabolic syndrome?
Yeah. Actually, you're right. I think the majority of the South Asian heart disease goes to the pathway of metabolic pathway, pre-diabetes, diabetes, insulin resistance, and then the whole syndrome develops. But there are some areas like genetics and just pure inflammation also play a part. But at the end of the day, when you develop atherosclerosis, multiple pathway merge and the inflammation sets in, plaque rupture, and then all these acute coronary syndromes. But you're right, percentage-wise, I would say the diabetic pathway plays the major role.
Interestingly, the Masala trial also showed there is higher prevalence of gestational diabetes.
Yeah.
And that is obviously not related to, could be related to some genetic reasons why they should have insulin resistance.
Yes.
But so everything is coming back to genetics rather than, gaining weight, adiposity, everything related to more of genetics in that case?
I would say epigenetics.
Because gestational diabetes is also epigenetics.
So there's a whole talk we can talk about how the fetal malnutrition, undernutrition when exposed. This is a long story about epigenetics. How, what we are, what our grandmothers ate. This is the story. At some point in our previous life, there was a famine and the genes got down-regulated. And these are the people who are born out of undernourished mothers when they're exposed somehow down the road because of environment or because of epigenetic modifications. This is a whole explosion or tsunami of diabetes and heart disease in South Asians. So there's a whole new talk, but you're right, fundamentally, this is the problem.
There's a question from the viewers.
So when you come to profile...
there's a question from the viewers. Is the risk same for women and men as per the genetic studies, Dr. Sharma?
The genetic score is genetic score that Dr. Amit Khaira from Harvard has come up that includes all the known genes and on the GWAS, and one of the most common ones, and then he sampled the samples from South Asians, and they are irrespective of the gender, and there are few genes that is compiled that will help us to further stratify our risk. Yes.
All right. There's one more question from the viewers. Are the South Asian with CVD more at risk of COVID-19?
So that's a very, I'm sorry, my slide presentation got messed up. So the one I had, I wanted to talk about COVID too. Now, this has been shown, and we know by the data, but this has been shown that as a South Asian, we are more prone to a metabolic syndrome, people with obesity, diabetes, low HDL, and somehow we are much more prone to develop COVID disease. Not only that, we are much more prone to develop complications and death from COVID because of our phenotype. Yes.
All right. Yeah, Dr. Namboodiri, you were saying something.
No, fine. So, do you suggest any role for primary prophylaxis with aspirin or statins in this population, or higher use of them?
Yeah, so there are studies. You mean the COVID population?
Sorry. No. More liberal use of aspirin and statin, especially with the primary prophylaxis view in general population.
Yes. Aspirin for South Asians, just because we are South Asian, we are a high risk. We are fighting a race. It's a race against our race. And actually, some epidemiologists think that our race is more important than the risk. I would strongly recommend aspirin 81, anyone South Asian, unless there is an active bleeding or the person is too old. So yes, aspirin and statin, definitely. I take it myself, and I get my calcium score, and I'm going to get my genetic test. So I think every South Asian in America or India should be proactive, prevent it. As you know, the South Asian heart disease is unfortunately 25% of the people when they have a heart attack could be fatal. So they died, they don't even know what they had, what they died from. And the disease, South Asian heart disease or coronary disease, is much more extensive, much more diffuse, much more proximal, less amenable to interventions. So we are a different animal. We are a different species, as you all know. Our South Asian heart disease is so bad, it's like a cancer. We call it a malignant heart disease. And it's not easy to diagnose, it's not easy to treat. What we can do is to prevent it, and prevent it at a primordial level, right from the kids, right from high schools. Teach them how to walk, how to exercise, what to eat, what not to do. And of course, as a holistic model, teach them how to take a deep breath, meditate and exercise and behave. That is only the solution we have. Otherwise, we will be wiped out. 1 out of 3 South Asian will die of a cardiovascular disease in America. Can you imagine? This is actually a wake-up call. We as a species, the South Asian, will be wiped out from South Asian heart disease, if not from the COVID second wave. I don't want to be alarmist. I just want to make sure people are getting the message.
Yeah, that's interesting. Would you recommend that yoga and meditation should be
Of course,
incorporated as a
yeah.
medical curriculum in all the medical colleges and institutions?
I absolutely do. I have another presentation, but I enjoyed the presentation from Dr. Khanra and Dr. Excellent talks. Yoga meditation have been approved by American Heart Association since 2017. There's a pathway that has been established. And one more thing, Dr. Khanra showed the slides were excellent, but how at a molecular and a genetic level, yoga meditation can downregulate the genes of inflammation. But there's another study that I wanted to share with you, that when you do spirituality and prayer, there is a group of people who have there are two groups of people. The people who have a meaning in life, and people who have spirituality, people who have a service attitude, somehow they also downregulate the genes of inflammation. So meaning is more important than being wealthy or than being happiness. People who are more happy and chase wealth, and they die early. People who give, people who serve, they do better and they live longer. So this is another pitch on becoming more spiritual oriented, because at a spirit level, which we don't believe as a scientist, there is a pathway that also helps. So I always include the axis of spirit, mind, and body. So at a spiritual level, when you pray and when you do something better, and when you meditate, things go down in the brain and hypothalamus, and then percolate all the way to your genes and DNA and epigenetics. So there's all things connected.
Yes.
So yeah, this is exciting conversation. So this is definitely a holistic model for heart disease.
Yes. Doctor, incidentally, I would like to share that there is this book called Mind Your DNA, which is been authored by me. And I would really like to share that with all the audience also, so that they get to read that how mind brings about changes in tackling stress. And at the genetic level, it has a very positive impact.
So one thing I would say, that people have been accustomed to this idea that DNA is the destiny. No, DNA is not destiny. You don't have to be depressed. Oh, this is what I have, I cannot do anything about it. Epigenetics is much more important. Epigenetics controls 80% of the disease and inflammation. That means that epigenetics empowers you to change your destiny. So you are the destiny, not your DNA.
Yes. There is, I think, one more question from the audience, from the viewers. Is the coronary calcium scoring effective in case of early onset? That's a quick question.
So this is the beauty. This is the beauty of coronary calcium score. No matter how you develop atherosclerosis because of genes, inflammation, or diabetes, once you get a coronary calcium score, you will know that you got it. And regardless of the pathogenesis, that is your number. Your coronary calcium score is your life score, because it will tell you exactly what is your risk, much more accurate than your body weight, your diabetes, your genes, because we cannot measure them and we don't have the tools. But coronary calcium score is simple, a screening tool of early stage of atherosclerosis. So get it done, and that way you can look at it, monitor it, get more motivated, and also decide whether you are the right person for aspirin or statin, blood pressure control, and you will be involved. You will be your own advocate and participate in your care. So it also helps you psychologically. You can see yourself, what's going on in your heart before there's another major disaster happen.
Okay. Thank you so much, Dr. Sharma, Dr. Dibbendhu, and Dr.
Okay.
Namboodiri for having this very wonderful and informative conversation. And I thank you all on behalf of American Academy of Yoga and Meditation. Thank you so much.
Thank you for inviting us. Thank you.